It's now my pleasure to introduce our first speaker this afternoon. Dr. Phil Mollica is a graduate of the University of Medicine and Dentistry, New Jersey Dental School. He holds a master's degree in human anatomy and a doctorate in integrative and naturopathic medicine. He's currently president and professor of the American College of Integrative Medicine and Dentistry, School of Integrative Biologic Dental Medicine. Dr. Mollica is an international, national lecturer and author. His private practice and research is located in Saddlebrook, New Jersey. Please give a warm Academy welcome to Dr. Phil Mollica.
Thanks, Pierre. Well, with that introduction, I think I'll leave before I lecture and I'll be okay. Anyhow, AGD disclaimer. I do not have any financial interest of a product in my talk or with any companies offering grant money for continuing dental and medical education. But I am talking about 3D cone beams, and if you come to Jersey, bring some cash. We got it right off the truck, right in your trunk. You got a 3D cone beam, no problem. Matter of fact, Dr. Fisher will help us with collecting the cash on that. Okay, good enough for Jersey. Okay, so what I want to talk about, I really want to give 3D cone beam. And it's in, about 2.5 years ago, I would say, we brought a 3D cone beam into our office. In our model of integrated medicine in dentistry, we want something that's a really objective way to look at the pathologies we're talking so much about. We talk about toxicities, we talk about failing root canals, we talk about osteonecrosis. Well, how do we visualize these things? How do we measure them? How do we know our therapies are really working? And also, how do we communicate with the medical community in a language that they understand? And I've found that through agencies that we work with, other physicians. We have to have that common language so they understand the concept of what is osteonecrosis. Well, we understand osteonecrosis. We understand these things. So communication is the key. And they understand CAT scans. This is something they understand. And this is what I want to bring you through today. Some of our practical applications on why we brought this technology in to a dental office. Let's see if this works. There we go. So, why spend up to $180,000, or our ICAT cost is $186,000, for an X-ray machine in the... Now, you could spend less. I have the iCat, and I'll show you a picture of that in a minute. And there's a baby iCat, and there's different systems out there. So you have some flexibility from maybe $100-something thousand all the way up to a couple of $1,000. It's always in my dear partner, my wife, and so I said, Kara, I said, we need some new technology. And she goes, uh-oh, trouble already. I need another toy in the dental office, but it's really important that we do this. So let's go looking for a 3D cone beam technology. Well, as we did with our computers, we traveled, we searched, and we keep on finding ourselves when we're looking for new technology. We wind up finding we're referring back to one system. In this particular case, it was always from Imaging Sciences, the iCat. Found that we fulfilled our... Now, we weren't so much interested in placing implants, but we want to look at the pathologic issues with head and neck. We're dealing in dentistry. What do we deal with? We deal with trauma. We deal with infection. Our world is filled with infection in dentistry. So this is a way to visualize that. And of course, I said, well, Kara, I says, it's only about $180,000. What could that extrapolate out to a month? Well, on the economics, if you're going to 3D cone beam into your office, you can forget about it paying for itself. I'm telling you right now, it does not pay for itself. But how it is paid is by the amount of things that you can see, and the work that you do certainly more than carries and covers the technology that you brought in. Because it's a great visual for you and a great visual for your patients, and that's very important. And also you can share this technology with your fellow practitioners. Off a 3D cone beam, You can download a CD, export a CD that has all the same imaging and all the software that you can give to your physician, give to your fellow dentist, so the understanding and can visualize these. So why spend $180,000 for an X-ray machine? If I can get this to work. It's for the view, man. It's for the view. I can view it all over. And I say to the patient, when this pops up, that's the true you. And also, to go where no 2D dentist has gone before. Because let me tell you something. When you look at a panoramic X-ray or a PA, you say, wow, that doesn't look too bad. And then you start hovering in on 3D cone beam and coming in left, right, up and down. You go, woo, where did that come from? Where did that come from? Let me go back a little bit. There we go. So the concept of 3D cone beam, has what's called multiple volume renderings, different things we can get from it. Or, many cool ways to see stuff within the head and neck. And the beauty of it is that you take one image and you'll have a multiplicity of different views you never had before. It's not like you have to take some SAS, I have to do this or that. One shot, you've got it all. And we'll explain these kind of interesting pictures as we go along. This is the ICAT from Imaging Sciences that we have in our office. And it's a great little instrument. It has a low footprint in the office itself. It's over in the corner. The patient sits in the chair, and you can adjust the chair up and down. And then this little thing spins right around the patient itself. Right across here, which I don't have a picture of, and I learned this from my pal Tom Colpitz, who spoke about 3D cone beam about a year ago. We had a little computer screen. He says, Phil, I have like a 60-inch TV to project my stuff. So I couldn't go 60 inches. I went 48 over here. So what happens is the patient, I take the picture, and then patient sits there, the volume renders through, and then we have a beautiful 48-inch screen of all these images. So what I'm going to do with the patient is sitting right here, I'm right here, sitting there. We can go through these pictures and they can visualize what's going on in the head and neck. Why do they have these particular problems? Why is there chronic fatigue, cancers, etc.? So it's very interesting to have this type of technology. So, some of the images that we get 3D volume rendering. We can get a three-dimensional model of the cranium. Now, this is the field of view. We can shrink this down, we can expand that, and I'll show you a couple of cases where it has great value. So we can get a real 3D model. It's fantastic. We can rotate this around, look at the little crevices, and a lot of times back by these, wisdom teeth, we see these osteonecrotic lesions with holes in the jaw. We can visualize, there they are. We get temporomandibular views. We can get the classical view, the medial lateral view, the anterior posterior view. This is all in one shot. And we can create three-dimensional models of the condylar heads. That's pretty cool. I can deal with that. It's one shot. Does that all. Quick on the trigger here. I love this stuff. Cross-sectional views. And we can actually get it down to where a couple of little millimeter slices are smaller. We can actually take sectional views of the dentition itself. Look at the cortical plate. Look at the medullary canal. Look at the inferior alveolar neurovascular bundle. Hey, look at this root canal. Uh-oh, what's that? They didn't use ozone. Airways. Sleep apnea. On the same picture, we can analyze the airway. And you know what? I didn't bring this with me, but you can actually get a three-dimensional model of the airway. And rotate and look around. All the students that come to the school, everybody gets an ICAT. So we get to look at, they go and they go, oh my God. Okay? So we can get a three-dimensional model of their airway. Ceph views. Ortho world, man. We can take a look. Lateral skull views, we can coronal views, all in one shot. And this I love, multiple projection renderings where coronal and axial views. Now, what's cool about this is that with the coronal views, we can actually move forward and back. We move the cursor and we can slide all the way forward and slide all the way back. We get a three-dimensional view as we're sliding through. On the axial view, I tell the patients, oh, start up here, and we're going to work our way through. And as we're working our way through, I give you the script, the anatomy that we're dealing with. I mean, in this particular case, we're looking at root tips. We're looking down into somebody's root tips. How cool is that? And a lot of times, like on these maxillary teeth, we look at the typical PA, we come down, all of a sudden, there's a big black hole in between these roots. Wow, the infection was in there, but it was blocked out by the buccal plate. How cool is that? So we can go up and down, forward or back, and we can rotate around. Get multiple projection views with this one simple shot. But what's important to us, and this is one of the reasons we brought the 3D cone beam technology into the office, that we've been, as you well know, doing work with ozone for a dozen years now. And we've seen this bisphosphonate issue coming along, being worse and worse and worse. And we wanted some way to say, okay, here we are, this is what we have today. We're doing our treatments, and what are the ultimate outcomes, and can we measure this? We always thought cavitational, what we call cavitational osteonecrosis, or infective osteonecrosis, was really problematic. That's not problematic. What problematic is when all your osteoclasts fall away and are poisoned. That's problematic. But we have this thing called Hounsfield units, so we can actually measure bone density. Now, typical bone will be in the range of about 400. You get into medullary spaces, it drops down to around 200. But you get into these areas where you have infective states, where you're losing density, the body's trying to buffer the infection you're dealing with, you get loss of density. So if we're treating these areas, at least we know we can measure objectively, okay, where we are at the beginning, during the treatment, at the end. Are we doing anything? Are we seeing remineralization? Because in bone, if you see remineralization, you've arrested the infection. Pure physiology, pure biochemistry. So we have a way now we can measure and visualize things. So the application of cone beam volumetric imaging, as you can see, we can do 3D virtual model construction, airway studies, bone structure, osteonecrosis and associated pathology, implant placement. There's third-party software, which is cool. You know, Palmer and I were talking yesterday. It's stuff called in vivo. We can take implant systems and place them right in, so you know exactly where you're going with them. Odontogenic lesions, TM joint visualization. What's real interesting, we'll see today, parasinus evaluation. It's amazing how much the sinuses are involved in these infective states, and I don't know if we're recognizing that a lot. So we don't know what the horse in the cart is. And of course, traumatic issues, and of course, we're looking for osteogenic healing processes. We're looking for things that indicate there's healing going on. And of course, like my pal Bob Harris, he loves coming in and talking about orthodontic assessment and all the orthopedics with that. He's great with that. So let's look at a couple of cases that were very interesting. This is what's called a true pan. It comes off. And the beauty of it, like with an iCat, most of these systems, you get a beautiful panoramic x-ray. And then from there, everything's extrapolated out, some of the views I saw. Let's talk about neurogenic facial pain. This is a golf pro that came into our office. And a couple of years ago, he had an implant that went bad. So he had the tooth extracted, the implant extracted. And unfortunately, what happened, there was multiple damage done to the other dentition. So he wound up having the implant out and the 3 associated teeth, some light-handed surgeon. What? Anyhow, he's a 52-year-old guy. His chief complaint was continuous, severe burning pain in my face. It never stops. It's been going on for 2 years. This is the type of patient comes in that everybody loves, okay? I did a lot of all and had a residency in it. He comes in, doc, if you don't cure me, I'm going to kill myself right here. Oh, okay, here we go. All right? But he's doing well. The history is, you know, the patient had a failing implant, like I told you. They took it out. Somehow, the other 3 teeth were damaged. He wound up with no teeth. It developed into some searing facial pain. And he came in, it's like a 2-year process going on. So he's gone to multiple dentists, you know, he brought his panoramics in, you know, physicians, the whole thing, you know, give him Neuronsens, all kinds of stuff. And this stuff was still breaking through. So what I do with, I try to figure out, okay, where's the root cause? And the trick with pain is, as you well know, is you try to shut it off. If I can shut off the pain, that tells me where it is. So what do? I do some diagnostic blocks. So he has facial pain, so let me give him, a superior alveolar nerve block. Let me block that out, get him numb, a couple of little spots here and there. So he's getting a little bit. He says, oh, it feels better. It's down to like a 7 or 6, but it's still pounding through. I'm saying, this is kind of strange. The guy, you can hit him with a baseball bat. This pain is coming through. I know I got his whole maxilla numb. Something I'm missing here. He says, okay, cone beam time, because he has some x-rays. I don't know if I want the x-rays. I said, listen, with the cone beam, you're going to give the patient exposure about like a traditional full mouth series. That's it. That's what the exposure you're going to get on this thing. But you need the information. So we take a cone beam on this gentleman. So, once again, we start going through our renderings. You saw the pan. I mean, you look at this. I mean, I have all kinds of cool things to look at. I'm looking here. I mean, everything looks pretty normal. There's no big holes in his head and all kinds of stuff that I can see here. I says, okay, well, let's take a little bit different view. Whoa. We start going through sectional views. All of a sudden, behind this edentulous maxillary area, I see this large lesion develop right here. And what is this right here? Incisive foramen. Okay, the incisive nerve coming down here. So I see this large hole here. We take another projection view. We can see this here. And once again, another sectional view, that part where we're coming up and down. All of a sudden, we're visualizing a hole in his head. So the traditional radiology was showing, well, it looks pretty good. But as we go through sectional views, wow, this is kind of sticking out. Now, the beauty of the system is, in most of these radiology systems have it where, when in doubt, refer it out. Well, we have the capability of taking the cone beam, the information from the cone beam, and actually just emailing it off to a radiology group. I use Radiology 360 down in Atlanta, so I hook it up. Software's right there, right down to the radiology group. After I saw this, I actually went up there, did a little nerve block right up here. Guess what happened? Pain went away. Pain went away. So the information I got back from the radiology group, you can actually, with this system, actually measure things exactly. It's a low density area, give the complete descriptive of the lesion itself. So this guy's running around for a couple of years, thinking it's brain, nerve damage. We found the lesion that was traumatically induced. There we go. So the descriptive back from the radiologist, a low density area, a high density area within it's consistent with a possible iatrogenic lesion, although odontoma cannot be ruled out, which it wasn't. The area is most probably a result of past dental treatment. Well, we know that. So you can see here a 3D model rendering, there's a hole in the jawbone. So we sent that, we downloaded the scan, sent him off to an oral surgeon who went up there and carefully debride and clean that area. The nerve was wrapped up in it, a granulomatoous type of tissue. Debride it. Guess what? He's fine. He cleaned up that lesion. Now he's full drugs. As a matter of fact, he's back on the pro tour, and I'm going to see him in a couple of weeks. So, oh, you're the greatest. No, we got lucky, and we had some technology to visualize something that we wouldn't have seen before. Thank you, man. This is a Palomine that's a failing root canal tooth. Now, in the typical model, you take a look at this, we can see that failing root canal and that distal root there. A nice little ball. Up right out. Well, how true is that? When we take our sectional views of the root canal, we'll start on the mesial aspect of the roots here. And we start to work our way through, and we start to get close. You see the medullary area start to decalcify here. As we're getting on the distal mesial aspect of the distal root, we start to see these areas start to dissolve up and try to buffer out. We'll get some more information there. Once again, as we're going through the roots, and as the roots disappear, Nestor, he was my friend. Thank you, Nestor. Ever try that one? What? That works. Oh yes. This multiple projecting, we can actually go through with slicing over mesially distally, and look how the bone starts to dissolve out. I mean, the body tries to naturally buffer these systems. We know it's infective state. We're getting prothrombotic bacteria. It's an anaerobic type of system. We're getting acid here, and look how the body's trying to buffer this. So now we're going in here. Look, as we're going through the tooth distally, we're seeing it's perforating the lingual plate, the infection. We go further back. Now, we see it even going here. Now we're starting to see the molar behind the root canal itself. So now when you're thinking about it, we're not thinking two-dimensionally on this infection, but it's a three-dimensional picture you're starting to put together associated with this infective state. So now we're seeing the extent of this infection coming off this particular root canal, breaking out the lingual plate of the bone, extending down and infecting all the way down. This is where you could possibly get some of this neuralgic type of pain. Now, these are like wormholes. We talk about this all the time with ozone therapies. When you find these wormholes working their way through bones, how do you follow that? Well, at least now we can follow it and measure that. And the interesting thing is we take a three-dimensional picture, look at the hole in the bone right here. I mean, how would you see that? You can't. These are great things that you can do with a 3D volume cone beam. Now, this is an interesting case. We talked about the association of disease, and that's a possibility. How do we really prove that? I don't know. But this is a case where we found osteonecrosis with an impacted wisdom tooth. Now, we look at a pan. I don't see nothing over here. This looks, it's got some, crazy stuff maybe over here, but, I mean, what are we looking at? We take a Seth. Holy cow. He's got this wisdom tooth jammed up in here, and all this dark radiolucent area here. But it's something interesting going on with this tooth, which, did not appear in the oral cavity. We look at a cross-sectional view of the tooth. What happened here is there was actually a hole in the gum here, where the tooth was actually decayed underneath the tooth, underneath the gum, and creating this parasinus infection. This whole area is infected. So what I want to do now is, let's take a little tour of how this tooth is, what's producing here. We'll take a, osteonecrosis, parasinus infection. Working mesially, okay, right off the distal at first bicuspid, let's work our way back through the tooth. Here's the maxillary sinus. Here's the turbinates. Now, this whole area should be clear. We're talking about an infection, okay, a low-grade constant infection in here, affecting the sinuses. This is self-perpetuating itself. So we're moving, once again, mesially, we're working our way distally. We can, once again, we start to see the bone. The density is very low. We see the parasinus infective components, inflammatory reaction here, working our way further back. Hole in the bone. We start to see the dentition itself, the infection right around the tooth itself. Look at this tooth here. The hole in the tooth. And it's totally submerged under the gum. You wouldn't know it's there. And interestingly enough, this is on his left side. This is all being cleaned up. And you know what? I just spoke to him the other day. The cancer, this is weird. Now, I'm not saying there's no connection. I'm not saying anything. But he's actually, the rectal cancer on that side is actually receding and responding to alternative therapies right now, once this area is now cleaned up, which is very interesting. Coincidence? Maybe. As we work our way through, look at the hole in this tooth and the associated infection up in the sinus. Remember, with infection, we look at foci of infection. Infection's everywhere, okay? It's just how much is in a particular area. So when we think, this little spot's infected, it's much more dispersed than that, okay? And once again, we're going distal past that. We can see the raggy-tag bone here, and we can measure these densities, and we will when he gets back, and we go through there, okay? Now, that's interesting. Now, correlation, that things aren't just right where they are. Let's take a look at a case where we're talking extraction associated with osteonecrosis. Now, this is the classic case that everybody sees in the panoramic x-ray, okay? An extraction site here. Okay, we see that low density area coming up, and sometimes you see the outlines of the root. When did you have that tooth extracted? Oh, I can't remember. It has to be at least 10 years ago. Okay, all right. We still have this low density area here. Well, why don't we take let's go in, let's travel in. to this area. We take a look, quick little snapshots. What's interesting, we're seeing these low-density areas associated with the medullary aspect of the mandibular bone itself. Cortical plate's intact, but we're seeing these weird kind of hole areas in the bone itself. Well, that's cool, but once again, let's take a little tour. Let's travel in there itself. Once again, going mesially to distally, traveling through. Once again, oh, well, that bone doesn't look too bad. Here's the inferior alveolar neurovascular bundle area. You're starting to see a little change in the bone here, cortical plate. But let's start to travel back. Now we're starting to see some bony changes going on here as we're going further back. We're seeing these infective areas here. Sclerosing. Changes around. Now we're looking three-dimensionally into this area. Now we're starting to get where that extraction was. Bigger and bigger as we're going through. Okay, now we're approaching that distal molar. Now the trick here is this. Well, okay, gee, is this thing just strictly located in the area that we obviously? No, it continues on. We can follow this track right around that molar itself, right through. Gets a little bit bigger. It's all three-dimensional. Once again, here. As we're working our way back, we're starting to see the remnants of the rami of the mandible itself. Here itself, and then it starts to clear out a little bit. So now we're thinking three-dimensionally. How do we measure these things? We can at least visualize this and get a sense of what we're doing. And once again, we're starting to get some compactness here. Failing root canal. Once again, let's take a look. This lady has multiple root canals. She's had breast cancer twice, okay? You think there's an issue? This is a quick snapshot. You can look at the apices of the root canals. How do we see this? We look here. Well, that doesn't look too bad. Maybe a little ratty, but look at this. Those infections around the root canal itself. They give you a sense of that. So whatever form of treatment you do, at least you know what you're dealing with. This is a bisphosphonate case, bisphosphonate necrosis here, where this gentleman with 64-year-old male, you know, his chief complaint is I have pain and pus coming from an area in my teeth where my teeth were pulled about 6 months ago. We got him about 6 months down the road. And the doctor said, well, there's no treatment for you. There's no treatment we can do for you. And it's basically his past history. He's a prostate cancer person. He went through, the radiation chemotherapies, and of course they gave him a couple of doses of Zometa to prevent invasive, carcinoma into his bones. Well, of course we know the side effects of that. And his history really was that, after he had all that treatment, he had a bad tooth. And going on that particular time, the dentist really didn't understand the phosphonate, especially on the IV levels initially. Most people right now are well beyond the IVs on the oral medication. So he went and had a tooth pulled. Okay, that's fine. Well, he goes back a week later, the tooth hurts. What do you initially think? Well, it's like dry socket. So what do? Go in there, scrape it up. Okay, if it's fine, give me a call if you have a problem. Well, once again, he goes back for a few weeks. And then, of course, you get to the point where, you can't get this thing under control. Where do you go? You send it what? To the oral surgeon. So what does the oral surgeon do? Go up there, clean it really up. But unfortunately, it doesn't heal. So he was diagnosed with bisphosphonate-associated osteonecrosis, and he went what's called a super infection. Okay, super infection. They could not control it. You remember, when you're talking about ischemic issues where there's no blood flow, how do you get these antibiotics into the area? You can't. So this is where you do localized therapies. You integrate a bunch of little different biological things, oxygenozone, maybe hyperbarics, vitamin C, all kinds of little tricks, which we don't have time to really get into. So when we look at a case like this, we take the little ceph, we can see where, in this particular case, you see the distal aspect of the maxilla at that particular time was perfing through the tissue itself. And ultimately what happened is, as we went through this healing process, the bone eventually cleaves itself off and releases. And then you have to kind of gut that process along and support the healing process through a bunch of different little therapies. But here, if you look at this piece of bone, I've shown this before because this is like the prize case. I mean, it just blows your mind. This hunk came out of here. And what you see here is the floor of the maxillary sinus, and this is where the dentition were, where they took out. So this whole area actually cleaved itself. Now, how do you monitor it and so the extent of it? Well, you have to visualize this. Once again, with our multiple imagings, as the healing process go on, this is where that distal aspect, that hunk of bone was sticking out on the distal aspect of the maxilla. You can go through sectional views, go up and down and see his entire, if you see this here, is his maxillary sinus, okay? Over here on the side of the insult, which is his right side, it's totally obliterated. There is no maxillary sinus. As we work our way down, we're up high, working our way down, we see the first remnants of the maxilla. Once again, we still see the maxillary sinus. We see some turbinates here. But once again, this is obliterated. Okay? All inflammatory tissue here blocking in. We're working our way down inferiorly. Once again, we start to see the root tips of the maxilla itself. And we're working our way into here, which is really representative of this void here. So you can do a correlation. Now, through our biologic protocols, this was the end result. We're here, all that raggedy tan bone is gone, and we're able to support his natural healing process. And ultimately, from getting rid of the infection, getting the granulation, and actually re-healing of the epithelial tissue here, he was actually become healthy enough where he actually went for a little plastic surgery and had a buccal fold put over to cover this defect. He was healthy enough at that point to have that done, so we can put a little prosthetic on there, which is going to be an interesting trick unto itself. So when you look at before and afters, you really can see now, this is where we were before on a SEP, and then we go across here, you can see where the bone is all cleared. Now this here, this is up in his maxillary sinus area. This whole area of his maxilla is gone with the teeth. This is some of the things we're really going to be seeing more and more of. And we do it three-dimensional. Look at this. How much of his bone's gone associated with that bisphosphonate. Pretty dramatic. Pretty dramatic. But we can visualize this in a different way. And once again, this one lady came in. She was having kind of weird neuralgic type pain. She didn't know what's wrong. We took the 3D cone beam, and we discovered a root down here. Now, if you want to go root fishing, that's one thing, and you kind of sometimes go blind. But with this technology, we can actually measure and get a sense of where this root tip is. Okay? So I'm going back X amount of millimeters, down a few millimeters, which is helpful when you want to go play. But once again, we can go on this cross-sectional view here as we're working our way through. We can see the root tip sitting in these areas. And it's funny, going through these cones where there were extractions done, it's amazing how many little root tips were left behind at one time. Okay? We find that all the time up there. Whether we go fishing or not, that remains to be seen. Okay? Well, may the view be with you, and that's my new little baby Darla, my little bulldog. I have a male bulldog. He's 5 years old, and I told him I'd get him a bride, and I brought Darla in from Germany, so a male older bride. And Tanky's a very happy boy these days. So, and Darla's doing well. Darla's about 4 months old right now, and she's a beauty. Any questions, all, which I can't take? Ha ha, there you go.